Mute, mute, mute.
Good evening, everybody. I'm Dr. Gayatri Egbot. I'm consultant rheumatologist at Sancheti Hospital. So today we are going to discuss about the new kid on the block, that is Tofacitinib. It is not really the new kid, but suddenly there are many companies who are coming in the picture, and now many people are going to use it. So I think we should hear it from the rheumatologist first of all. So I'm very happy that today my dear friend and colleague Dr. Abhishek Zanwar is going to give this talk. He's done his DM clinical immunology and rheumatology from prestigious Sanjay Gandhi Postgraduate Institute, Lucknow. Then he is also a consultant rheumatologist at Ruby Hall Clinic, Pune. He is also a consultant at Pune Super Speciality Clinic, Pune. Then we have a panelist, Dr. Ajit Nalawade sir. Sir is one of the senior most rheumatologists in Pune, and he has multiple achievements. He's a fellow of American College of Rheumatology, has done ULAR course. Then there are many other achievements. Sir heads the Department of Rheumatology in Sancheti Hospital, Pune. He's also a consultant at Pain and Arthritis Clinic. Then we have Dr. Nilesh Patil. He has done his rheumatology training, has done fellowship from very prestigious Indian Spinal Injury Center, Delhi. Then he's consultant at Sancheti Hospital, Pune. And I'm very happy that this is our team at Sancheti Hospital. So yes, over to you, Dr. Abhishek. So he's going to discuss about Tofacitinib.
Thank you, organizers, for giving me this chance to discuss about this new molecule. As Dr. Gayatri said, it's not really very new molecule as such. But last month on 24th, suddenly all 7 companies across India launched this molecule. And I started getting wake-up calls from my fellow orthopedicians. What is this, Jack? Come on, tell us. And so I thought I will just share my thoughts about this molecule. So what is JANUS? What really is JANUS? So Janus is named after Roman god of doors and time. In fact, the month of January is also named after it. And it's supposed to be two-faced, one looking in backward and another looking into forward, allowing the god to study past while peering into the future. So so as we said, one face look in the past, another phase look into future. So just like this, whenever there is cytokine engagement with receptor, this JAK-STAT pathway needs 2 subunits for their activation. A single subunit cannot be activated, and so that the downstream pathways will be activated. Both these subunits are similar, though they can be different, but the overall structure is similar. So this JAK-STAT pathway, the Janus kinase, is named after this. The basic concept is being like 2 similar units facing opposite. So since I said this is supposed to be a new era or supposed to be a new blockbuster drug, but before going into the future, I would like to go a little bit in the past. And so this was the paper. This is like Dr. Henge and Dr. Kendall, and this was the first paper when they have described use of hydrocortisone, the compound E, for treatment of rheumatoid arthritis. And till this time, actually, the patients with rheumatoid arthritis were suffering without any definitive treatment. And the steroids really showed dramatic improvement. And this work led them winner of Nobel Prize in 1950. But soon it was realized that steroid has its own adverse effects in long run. And then the efforts were carried out to find some steroid sparing agent, though there was some luck with gold and penicillamine, but they also had their own toxicity in the form of renal toxicity and liver toxicity. Till 1960, when a very Indian Dr. Subbarao discovered the molecule named methotrexate. And I must say, even after more than 50 years, it's still a cornerstone of treatment for rheumatoid arthritis. This work is no less than any Nobel laureate. And I must say, the the transition from high dose to low dose methotrexate pulse has standard test of time, and it's still cornerstone of, and it's still first line of therapy for rheumatoid arthritis management. This was the second milestone. And then came 1990. Again, these three scientists, Dr. Jain, Kohler, and Milestone, received Nobel Prize for Medicine in 1984 for their path-breaking discovery of synthesis of monoclonal antibody. And in 1990, it has seen from bench to bedside. And Dr. Ravindra Maini, again, an Indian rheumatologist, popularized and first used the molecule infliximab for rheumatoid arthritis. So very seldom one disease gets so much Nobel Prize laureates, and rheumatoid arthritis had still given chance to conquer this disease beyond the physician and clinician's capabilities. So this was the second milestone, I would say, in terms of disease-modifying agents. Then came this molecule, JANUS kinase inhibitor. So I would just go into some basic details. So infliximab or molecules like monoclonal antibody, they block here. In the figure it is named as 1. So the cytokine, one selective cytokine is either blocked by binding to its receptor or it's scavenged outside the body. What happens after cytokine engagement is the recruitment of JAK-STAT, both JAK unit and STAT units, and leading to activation of JAK-STAT pathway, which ultimately lead to transcription of target genes, which are usually cytokines, and increased production of cytokine further lead to recruitment of the inflammatory cells. So this is perpetual cycle. Cytokines activate JAK-STAT pathway again activate, leading to further cytokine production, which leads to influx of immune cell, which causes tissue damage and again further causes cytokine release. And this cycle is very difficult to break unless we use any disease modifying agent. So as I said, cytokine blocking antibodies acts here, but the JAK pathway, these new molecules, JANUS kinase inhibitor, JAK-inhibitors, they block pathway here, more downstream. So they are supposed to be quite effective in blocking transmission and halting the perpetuatory cycle of JAK-STAT pathway activation and cytokine. So this was basic about it. Then there are, I won't go into much detail into this, but different cytokines have their different own JAK and STAT for activation. This is list, you can it's available online, you can go anytime into details. And this is I will just highlight few of them. The interleukin 6, and which is supposed to be one of the key cytokine in pathogenesis of rheumatoid arthritis, is it activates JAK1, JAK2 and TIC, and it activates STAT1, 2, 3. The interferonopathy like lupus or myositis, they activate JAK1 and JAK2. And interleukin 12, 23, which is supposed to be pathogenic in spondyloarthropathy, activate JAK1 and TIC2. So, so it was year 2012 when they tried Tofacitinib versus placebo. It had shown really impressive result, ACR20 response rate of 60%, and the DAS20 remission of more than like 15% as compared to placebo. After this, they have done Tofacitinib versus Methotrexate, which is supposed to be the first line of DMARD for this rheumatoid arthritis management. And again, it showed superiority over Methotrexate in terms of ACR20 response, ACR50 response, and ACR70 response, and proportion of patient achieving DAS28 remission. Then they have done, they have gone more further, and they have tried giving Tofacitinib in patients with inadequate response to Methotrexate. And again, in this patient also, they have shown quite great results. ACR 20 response of almost 62% at 6 months, and DAS 28 remission in almost 16%. And consistent result were shown even with combination and even as a monotherapy. Then came the another class, more difficult to treat RA, biologics refractive RA. Even in these cases, to certain extent, it has shown some efficacy, even at 3 months and 6 months, consistent effect, both with tofacitinib 5 milligram and 10 milligram. So, and this was the recent trial comparing the blockbuster biologics anti-TNF, which has stayed on horizon for almost like 20 years, versus tofacitinib. And not to surprise, but it has shown equal efficacy compared to biologic. This is oral tablet, and adalimumab is parenteral administration. Most of the biologics have parenteral admission. So this was something very new and unique, that a simple molecule which can be taken orally can be as effective as biologics. So far, then there have been multiple studies, systematic meta-analysis and reviews, and it has shown consistent result that tofacitinib can be as good as adalimumab, and it's superior to methotrexate. So this was our JAK. So far, so good. Everybody is happy with results, but there is always something beyond all good news. And I must say, till date, based on preliminary studies, based on the preclinical studies, they have excluded certain set of patients from trial. All this data is from trial, and they have quite strict exclusion criteria for inclusion in the trial. So the adverse event where these are, I have listed a major adverse event in this from this data. So the major adverse event was anemia, neutropenia, sepsis, lymphopenia, dyslipidemia, hepatotoxicity, and in some patients, rise in creatinine level. So yeah. So having said this, I will just go little detail into it. So safety data was based on preclinical studies. Already they have excluded patients with anemia, hemoglobin less than 9, patient who had active or latent or inadequately treated Mycobacterium tuberculosis infection, pregnant patient they have excluded, and all patients who needed hospitalization because of infection in last 6 months were excluded from the participating into the study because of the fear of infection. So this was the meta-analysis about safety data of tofacitinib from all major trial. It's quite comprehensive and included almost 4,000, more than 4,000 cases of tofacitinib till date. And if you see, proportion of patients who discontinued tofacitinib due to serious adverse event were quite high, going way up to 28%, 24%, 25%, despite already having strict exclusion criteria. So what were these side effects? I will just highlight few which can be the more relevant to our real life. Urinary tract infection in 15% almost, bronchitis, lower respiratory tract infection in 13%, and herpes zoster in almost 12%. The influenza was also quite common, almost up to 7 to 5%. So these were the major event which led discontinuation of the tofacitinib in this set of population. Lab parameters, as far as concerned, asymptomatic rise in creatinine kinase was seen almost up to 8%, and more than 3 times raised. They were raised more than 3 times, so led to discontinuation. Liver enzyme being raised was found in 5 to 6%, and that led discontinuation, and creatinine rise was seen in almost 5%. So So far, there has been biologics treatment with mortality, and this drug is no different than that. And mortality has been observed in this trial data also. In approximately 4,000 patients, 20 cardiovascular deaths were attributable to use of tofacitinib, not overall mortality, but mortality which was related to drug. Due to cardiovascular events were almost 20. 13 patients died because of infection and 4 patients died because of malignancy. And these were related to drug, not unrelated to drug. So if we see, so far, most of the DMARDs have shown this consistent side effect of getting sepsis, infection, lymphopenia. But one unique side adverse event which was observed in these cases was deep venous thrombosis and pulmonary embolism. And major cardiovascular event was also seen in this patient. In fact, even gastrointestinal perforation were also observed in 23 patients. This is in quite contrast with the other DMARDs like methotrexate and anti-TNF, where in fact the use of this medicine lead to decreased cardiovascular risk. And so far the bridge therapies like corticosteroid or NSAID has been only observed to have increased risk of cardiovascular event. So maybe this is one of the DMARDs due to some unexplained factor which is showing paradoxical effect of increased cardiovascular mortality as compared to methotrexate and TNF inhibitor. So we have to be quite careful if we are using it in patients with ischemic heart disease or old patient with already having one or two cardiovascular risk factor. We have to be quite careful. So as far as the infection is concerned, this was another meta-analysis of consisting of almost 4,000 patients published in Annals of Rheumatic Disease. And they have observed the factors which can be associated with increased adverse event with use of tofacitinib. So far, I would like to draw your attention to from bottom. So if you see rest of the country doesn't differ much, but if the subject is habitating in Asia, does have higher risk of getting infections and adverse event. Could be possibly because of prevalence of still having prevalence of tuberculosis, and we are being like capital of diabetes and cardiovascular diseases in our country. Overall, the Southeast Asia region is almost like same in this regard. Another risk factor is baseline. If patient has baseline diabetes, the chances of getting infection is quite high. And if you are already using glucocorticoid, any glucocorticoid dose will again increase the risk of getting infection or adverse event. Old age, more than 65 years, again higher risk. And structural lung disease like COPD again increases the risk of having bronchitis. As I said before, all trials are based on quite strict exclusion criteria. The real life issues we have to face are quite different. And as we all are aware, almost 30 to 40% of rheumatoid arthritis patients already have some cardiovascular manifestation or some cardiovascular risk factor. And many times it's not quite strictly addressed and aggressively managed. So if we consider strictly demographic factors in India, there are 12% of patients with diabetes, so that's like 15 crore, like 15% cases of ischemic heart disease, 20 crore, and active cases, we are reporting almost 24 lakhs per year. And the latent tuberculosis in the household contacts in this patient can be almost 50%. Just to draw your attention to the high risk category patient, if you are planning to use in this patient, it could be troublesome in this kind of patient. Another issue is like loose drug regulation in our country. I would like to share one experience of mine. One of my patient was on Zelja and the Tofacitinib, and she was quite stable, and she had gone for treatment of dysmenorrhea and was prescribed Ocipil not unknowingly by gynecologists and landed up with deep venous thrombosis and pulmonary embolism. So many times even OC pills are taken just to postpone the menses in our country due to religious reason. And they not to highlight steroid use is quite rampant in the name of alternative medicine. So these two are one of the risk factor I think could possibly again lead to more incidence of DVT and steroid. Another issue is this tofacitinib is metabolized by CYP liver enzymes, and commonly used, abused antifungal and antibiotics can really cause drug interaction and increased level of tofacitinib. I'm just highlighting very few. There are many drug interaction, but these are the commonest one which you can encounter. And whenever we are initiating a patient, we have to be really careful about all these issues. So, so far, it's quite counterintuitive that a small molecule oral medicine would be safe than biologics like infliximab and adalimumab, which need parental admission and sometimes IPD admission also. But that's not true. If it is as efficacious as biologics, it is bound to have as many as side effect as biologics, and that doesn't mean oral medicine doesn't mean we have to monitor less frequently, less intensively, and that doesn't mean that it causes less infection. The risk of infection is quite same in both as far as biologics and the tofacitinib is concerned. It's less with methotrexate compared to the biologics and JAK inhibitors. But we still don't know much about this unique side effect of increased thrombosis, which is never has been seen with any DMARDs so far before, cardiovascular risk, and the real life issues like over-the-counter drug interaction that still need to be sorted out. So I don't want to scare you like this, what is happening, but just like to say we have to, it's very delicate balance, giving immunosuppression and patient going into sepsis or infection or into any complication is very thin line, and a slightest amount of even push can lead to a devastating complication for a patient. So just to say again, oral medicine doesn't mean it's very safe. It's good, but it has to be monitored in rigorously. It has to be used very carefully. So as I said, tofacitinib is one of them, and I would say it's we are presuming that the generic ones will have the same efficacy and same adverse event profile as the Xelja and the original molecule, but the data regarding generic tofacitinib is yet about to come. So as I said before, in 1950 we witnessed the discovery of steroid, then methotrexate, and then biologics. And I can definitely say by this decade is one of the decade which has led to discovery of and synthesis of many JAK inhibitors. Tofacitinib is just one of them, and we are yet to see another molecules also. I don't want to confuse with the complex figure. Just note down, almost more than 10 molecules so far has been already in pipeline. We have already seen baricitinib has made already way to the real life also. So which one will be more efficacious? Will there be any difference or not? Do we get to know any JAK inhibitors with less adverse event profile, more efficacy is still yet to be discovered. As I said, tofacitinib is non-selective JAK inhibitors, and the upadacitinib or filgotinib or solicitinib, these are more selective. Dericitinib is also more selective, and the trials are still being continued. Some of them have to be discontinued because of serious adverse event, and we still need more data to see what is coming up next. So I have just tried to give you a glimpse of a little bit past and future. Just want to say, as our title say, it's neither foe, neither afraid. It can be both. It depends on your use, how we are using it, and how we are balancing the benefit versus risk. So I would like to just say this quote from Spider-Man: "With great power comes the great responsibility." And this is our gift for a rheumatologist and all physicians and who are managing this rheumatoid arthritis. This is our gift, but it can be also our curse. Thank you.
Yes, so thank you, Dr. Abhishek, for this wonderful talk. And as you said very correctly, with great power comes the great responsibility. So obviously using tofacitinib or using JAK inhibitors is not everybody's cup of tea. And the companies who are making it so rampantly should understand that whom to advertise is very important, because at the end of the day, we are playing with somebody's life. As he said very rightly, it's not neither a friend nor a foe. It's just a oral molecule. That's its major advantage, and it is quite efficacious. So there is a question for you, Dr. Abhishek. Dr. Naresh is asking that is tofacitinib useful in ankylosing spondylitis? What are your thoughts about it?
Yeah, so far the till date phase 2 studies have been published and they have shown quite good result. And recently there has been a phase 3 trial which were presented in ACR 2020 by Dr. Atul Devdar, and both of them had really shown the efficacy of tofacitinib. At least the original Xeljanz, which it was used in that study in ankylosing spondylitis also. And it's quite comparable with anti-TNF molecules.
Okay, so it is useful so far.
Yes, yes.
So
it's still not approved, but it is, the studies are showing its effect, and maybe I think the price difference the economics wins over the science many times. So maybe the price difference between anti-TNF and JAK inhibitors will lead to the race again.
Yeah, and as you said, there are very few oral molecules available for angst.
Yes.
So probably this is one more advantage. Then I would like you to take this question, Dr. Nilesh sir. Is it useful in ulcerative colitis? Though we are rheumatologists, we are not gastroenterologists, but yes, we deal with many IBD cases associated with spondyloarthropathy. So I think we can take this question. So is it useful in ulcerative colitis? Dr. Jyoti is asking.
Yes, definitely. It is useful. But yet there are certain papers which have not come out with the full swing. So once they are available, definitely we can use it. Okay. And even the baricitinib is also coming up with good use in ulcerative colitis.
Right, and dose remains the same.
Yes.
Yeah, the dose in ulcerative colitis is, they have used it 10 milligram BD, and I think that has been associated with more thrombosis and side effect profile. But definitely we should use as less dose as possible.
Okay. Nalawade sir, this question is for you from Dr. Amin Shah. Have you used iguratimod, and can you compare tofacitinib with iguratimod? Though I don't think this question is quite valid because both of them have little different mechanism of action. But what are your thoughts, Nalawade sir? Because that is also one of the newer drugs in the market. Sir, can you unmute yourself, Ajit sir? Yes.
Basically, the question, I think it is coming up because of the aggressive marketing by various companies. In fact, now what I understand is iguratimod is more expensive than but actually it's not
monthly.
It is not as potent as JAK inhibitors, and it's not as proven as JAK inhibitors. And definitely, it doesn't compare with tofacitinib. So, I have not used iguratimod much. In fact, I must admit, only a few patients. And definitely, what I'll say is, if at all you have an indication, now the cost was the issue. It will be tofacitinib which can be used.
Yeah.
Iguratimod, maybe any other panelists who have used it can chip in their comments.
We just started using it. Yes.
It's if at all it might be having some modest effect, not like tofacitinib.
It is not that promising. You can't compare, I think, iguratimod with
Yeah, exactly. Then next question is for you, Dr. Abhishek. Dr. Israr Ahmed Khan is asking, so can you use it in psoriatic arthritis? And
Yes.
also one more question, like it's not his question. What are other indications apart from RA?
Yeah, so it can be used in psoriatic arthritis. The results have been quite comparable. In fact, the ACR20 response in psoriatic arthritis with baricitinib, not tofacitinib, was a little bit slightly superior to adalimumab in the trials, which was published in NEJM in 2007. So definitely, it can be used in psoriatic arthritis. It has been already approved in US and Europe, and even in India, it has been approved. The baricitinib has been approved, and the other indications still it has been approved officially for rheumatoid arthritis and psoriatic arthritis and ulcerative colitis. These are the three diseases. The results with other diseases like the lupus or the ankylosing spondylitis or the inflammatory myositis, till date phase 2 studies have been quite encouraging, and they are looking forward to multiply into many other diseases, but so far the official indication remains these three only.
Yeah, so rather there was a landmark study in NEJM in 2017, I think, which showed that tofacitinib is quite useful for skin psoriasis as well.
Yes,
so,
yes.
Yeah.
Even the PASI 75 and PASI 100 responses were documented. And I think in part it could be related to, like I said, interleukin 12-23 pathway is again regulated by the JAK-STAT pathway, which is one of the most important pathway in psoriatic arthritis.
Yes, sir. So, Ajit sir, I have a question for you. Like, there is one more small molecule which is apremilast, and since we are talking about psoriasis, can you really compare tofacitinib and apremilast? So, what do you think about
apremilast
and tofacitinib? Both are small molecules, and both are quite useful in psoriasis. So, could you compare these two?
See, apremilast again is not as effective as tofacitinib, but still it is a useful molecule.
Yes.
I would give it as a monotherapy, but if I combine with methotrexate, it really works. So if at all patients, now till date, what was the issue is patient is not responding or inadequately responding to methotrexate, and all rest, including tofacitinib, were in thousands per month. So then I would add apremilast, and then probably few of my patients have really benefited from that. But now that we have JAK inhibitors, which are very cheaper, maybe I would consider tofacitinib rather than apremilast. But definitely apremilast has a role.
Yeah. So for our dermatologist friends who are out there, this message is quite important. So Nilesh sir, this question is for you. So what kind of pre-workup or the checkup would you do before starting tofacitinib?
So we generally ask for the routine investigations, which we ask for biological before starting biological therapy.
Yeah.
So hepatitis B, hepatitis C, Mount stage, and TB gold for latent tuberculosis and X-ray chest.
Yes.
So they are the routine investigations we ask. And if possible, we try to vaccinate these patients so that the chance of infections are higher, so that we can reduce the chances.
Yes. So apart from your usual labs like CBC, RFT, because even create gets raised in few of the cases, LFT, I think Triple H, especially Hep B, Hep C, and Montu quantiferon gold are quite useful. And pregnancy is total contraindication, right? Okay. So I think that was a very indeed good session. So Dr. Abhishek, one last question is this last question is for you. So what are other apart from the just arthropathies, what are other indications where you could possibly use this tofacitinib?
Yeah, so in dermatology they have used for alopecia areata. Yes. They have also used for pure the skin psoriasis without arthritis. Even for skin psoriasis also they have used. Even there are reports in vitiligo also which have shown quite encouraging result. And I think they are trying to replicate. They are trying to see if it works in most of the dermatological conditions which have autoimmune basis.
Yes. And have you
And
used it in? Yeah, sorry.
yeah, I
Continue.
mean the recent COVID they have yeah, just now, I mean few weeks back they have approved use of baricitinib in at least severe COVID, moderate to severe COVID. I have not used it, but just being in news, so I would like to share.
So so since we are talking about COVID, because tofacitinib, high dose tofacitinib was associated with DVT and pulmonary embolism, and we have seen quite a few cases of pulmonary embolism with COVID. So I think probably that was the reason there was a lot of talk about tofacitinib and COVID, but it was not really used as much as tocilizumab was used. So so could you compare risk of DVT and pulmonary embolism of baricitinib and tofacitinib? Do you have any idea?
Yeah, I mean, so far, I think the risk remains same, and in fact, the risk of DVT. There is another third molecule named upadacitinib, and it has shown it is selective JAK inhibitor, JAK1 inhibitor, and that has shown even slightly, at least numerically, higher risk of DVT and pulmonary embolism compared to tofacitinib and baricitinib. So whether it is class effect or whether being non-specific or more specific does any difference, we still don't know. But definitely, tofacitinib and baricitinib have almost similar kind of result. Upadacitinib has got numerically higher incidence of DVT and pulmonary embolism.
Yes. So I think do we have it?
Yeah, I have few comments. Yes. And again, herpes zoster is one of the.
Yes.
And now, more importantly, I have question for all the panelists: whether you will take consent before initiating the project. So everybody has to answer one by one.
Nilesh sir, you can go first.
Yes. Yeah, it's a good thing to take a consent before starting this medicine. But when we will try to explain the risk and the chance of infection to the patient, then it will be really difficult to convince them that this molecule is really wonderful. You should just try. But it's really difficult to convince them. So, but to be on safer side, I think we should take the consent for all these patients, whoever we start on tofacitinib.
Dr. Abhishek,
I think sir's question is quite relevant because before every biologics we do take consent, but we are not accustomed to take consent before prescribing tablets, and this is where we can be into fix. And I think I would like to really take consent, especially all the old people with cardiovascular risk factor like diabetes and obese, definitely. And especially if you are using an ankylosing spondylitis where it's still not approved, but we would like to use or give benefit to patient just because of the economical reason, definitely I would like to take consent in both.
Yeah, sir, I think that was a very good point. It didn't occur to us, I think, at least to me. But I would also like to take consent because if we explain to patients otherwise so much, I think that's a better thing to take consent.
I'll share my experience with Olumiant. In fact, two of my patients whom I had initiated Olumiant ended up in ICU within 2 months with severe infection. In fact, one of them succumbed. So since then, I have started taking consent. It is important. It's not a simple molecule. And the reducing cost again doesn't make it so. We don't use drugs which are used by say like oncologists. There are many oral molecules available, imatinib and all. So basically such drugs we have to explain what are the risks, and the risks are real. So even if maybe around 3 to 4% in trials, but in real life probably it will go to around 5 to 10%. And if at all infections occur, that could be severe problems. Okay, so that is my take on it, but definitely risk benefit has to be there, especially patients with comorbidities should not be prescribed JAK inhibitors. I'll prefer TNF inhibitors or maybe even etanercept in those patients. So young with no other comorbidities, probably JAK inhibitors could find the place. So indications, again, I think should be justified if we initiate it, not just like we'll try this drug and we'll see and all those things. And proper guidelines, I feel everybody should follow. Everybody should start with methotrexate and try to see that it is not responding to that, etc., etc. Maybe unless data is available, it should not be tried as a first drug for any autoimmune conditions. That's what I feel, right? Any other comments then before we close?
Definitely, we should wait for some time. In the Indian scenario, there should be more cases, and then we'll be more confident about this.
And in fact, we are presuming that the generic one will have same safety. Just to presume, we will be very optimistic that they will have same adverse event profile and same efficacy. That will be really,
because the product might be same, but processes are different. Processes are patented, and we really don't know what will be the risk and what will be the benefit. So still, there are a lot of unanswered questions.
I think in current scenario, when everything fails, then only we should try. So we should try all other molecules, and then we should think of tofacitinib.
Tofacitinib, yes. So we have few questions. So this question is for Dr. Abhishek. Dr. Neha is asking, will you give tofacitinib to RA patient with CKD? I think he has answered partly in his presentation, but would you?
Yeah, it cannot be given. At least the drug manufacturing label contains that it can be used at max. If you want to use, you can use it at 5 milligram OD dose. That too also with strict monitoring. But I won't use it because already there has been. We have other options also. I think
exactly
lot safer option. So if I'm out of all options, maybe then. But otherwise, I don't see any reason to use it upfront.
Right. So this next question, Dr. Shrikant Jategaonkar is asking, this is little offbeat, but I think Nalavade sir, you can answer this. What about COVID vaccine in RA patient? Would you give? So he has not mentioned it specifically, but you can discuss about both RA in remission, active RA, RA on treatment. So his question is for COVID vaccine in RA patients.
Whatever understanding I have, currently whatever vaccines are being discussed, like Pfizer one or Moderna one in US, and the Oxford one, which Serum Institute of India is developing, all can be given in rheumatological conditions. The one which is being developed by Serum Institute is again a live attenuated vaccine, but it is there's some concept that it cannot so it can be used in RA. So as of now, all the three, if available, can be given to patients.
Yes. So, Dr. Abhishek, have you used tofacitinib in SLE patients or scleroderma patients? Have you, or are there any trials?
Yeah, I haven't used in any SLE or scleroderma patient so far. And SLE, I think phase 2 trial has been done. It has shown, but again, they have done quite strict exclusion criteria, antiphospholipid syndrome, antibodies, comorbidities, and all. I mean, like, it's not same as using it in rheumatoid arthritis. I think because the antiphospholipid syndrome, it can be seen in lupus patient almost up to 10%. So I'm not aware of any trial in scleroderma so far, but in SLE there has been already phase 2 trials have been published.
But it can be used in myopathy, inflammatory myositis.
Yes, it can be used in myositis. I have used it in one biologic refractory, rituximab refractory myositis, and it has shown result. But again, it's like off-label use. When you are out of all options, definitely you can give it a try.
Yes. So, Dr. Nilesh, sir, would you do herpes serology before starting tofacitinib?
Yeah, ideally we should do, because initially the vaccine was there in India, but now they have removed the vaccine. Still, we don't have the vaccine. We should do the herpes serology.
Okay, so this last question is for you, Nalawade sir. How would you monitor tofacitinib, like in methotrexate or leflunomide, or for other drugs? Like at least first in for we do labs every 4 to 6 weeks, then every 3 monthly, then 6 monthly. So how would you do it for tofacitinib?
So like any other drugs, as against to biologics, this is a small molecule and it can cause a lot of drug interactions. I wanted to just say that, and definitely I'll monitor it just like methotrexate and any other drugs. But beyond that, history taking and evaluation of patient for other comorbidities, other risk factors for infections, thrombosis is very important. So just like anybody evaluates patient for cardiovascular disease, we have to evaluate such patients for those risk factors also. So not only blood tests, but history taking and clinical examination remains important for tofacitinib.
Yes. So, that was indeed a wonderful session. So, since Naravada sir, you are our head, there is a request from audience that they want a session for on biologics from all of us.
So definitely on biologics,
Yeah, we will definitely do
one
it.
by one. So maybe next session we can have on biologics.
Okay. Fine. So thank you again, Dr. Abhishek, for joining us today, and thank you, Nilesh sir. Thank you, Dr. Nalawade sir, for being panelist. And obviously, I would like to thank Chaube sir and Ashok sir for their wonderful help, technical help especially. And thank you, Team Sancheti, Dr. Parag Sancheti sir, whose vision is quite broader, that he thought about this Rheumat TV. And most importantly, I would like to thank our wonderful audience. There have been there are actually many good. There is a good feedback about our Rheumat TV, and I think I hope we continue to do this nice activity in the future. Thank you.
Thank you, everyone.
Thank you. Okay.
Have a nice evening, everybody.
Yeah, same to
Yes.
you. Sir.